Bismillahirrahmanirrahim. This is Dr. Usman and welcome to my YouTube channel. Today we are going to start the thalassemia. Thalassemia is a very important disease and especially in our countries, in South Asia countries. It is a congenital defect of globin chain of hemoglobin in the RBC. We have hemoglobin, and hemoglobin consists of two parts. One is heme and one is globin. The heme part is composed of iron and protoporphyrin. These protoporphyrin combine with the iron, they form heme. While the globin chain consists of two alpha chains and two beta chains. Now, the types of hemoglobin the human can have. Hemoglobin A, which is called adult hemoglobin, which consists of two alpha chains and two beta chains. Another is fetal hemoglobin, hemoglobin F, which is two alpha chains and two gamma chain. One is hemoglobin A2, which consists of two alpha chains and two delta chain. Now normally we have 98% hemoglobin A in normal people, in adult people. While in adult people we have hemoglobin F, which is less than 1%, and another hemoglobin A2, which is less than 2%. Normally hemoglobin F present in the children up to 6 months. After 6 months, which is replaced by hemoglobin A. The main problem in thalassemia is when there is defect in the globin chain. Which chain is absent, the disease will lead to their type of thalassemia. Like for example, if the alpha chain is absent, we will call it alpha thalassemia. If beta chain is absent, we will call beta thalassemia. If the gamma chain is absent, we will call gamma thalassemia. If the delta chain is absent, we will call delta thalassemia. It is very important concept to understand. In autosomal recessive disorders, if both parents are carrying abnormal gene, then each pregnancy can have 25% chance that the baby can have thalasssemic disorder and thalasssemic major disorder. These both can be carrier and 25% babies can be normal as well. Now let's go into the classification of thalassemia. Basically, we can have 4 types of thalassemia because we have 4 globin chains. If alpha is absent, alpha thalassemia. If beta is absent, beta thalassemia. If gamma is absent, gamma thalassemia. If delta chain of globin is absent, we can call it delta thalassemia. But clinically, alpha thalassemia and beta thalassemia are very important for us to understand. First, we will discuss about alpha thalassemia. For alpha chain of globin, the loci of gene for the alpha chain is present on chromosome number 16. For that, they have 4 loci because there are 4 globin chains. Now look at the disease process. If one alpha gene is absent on chromosome number 16, then we call it alpha thalassemic trait and the patient must be asymptomatic. Now if 2 alpha chain globin chain gene is deleted, then alpha thalassemia minor. There will be no symptoms, still the patient will be asymptomatic, but there can be mild anemia because of the decreased MCV. Now, if the 3 gene on the chromosome number 16 is deleted, then we call it hemoglobin H disease. In this condition, because the alpha chain is so deficient, the beta chain will take over and there will be excessive beta chain. And there will be moderate to severe anemia. This must be hemolytic anemia. Now, the condition getting worse, and this is the worst case scenario. If all 4 gene for the alpha chain, alpha globin chain is absent. This is called hemoglobin Bart's disease, and this baby cannot survive, and this baby will be hydrocephalus. Now look at the beta thalassemia. Beta thalassemia, basically there will be deficient or absent beta chain globin. Now, if the beta chain is absent, the alpha chain will produce more. So there will be excessive alpha chains which will form insoluble inclusion bodies in the RBC. Now, in beta thalassemia, in RBC, when there is formation of inclusion body, there will be ineffective erythropoiesis in the bone marrow. These RBC are defective, and the macrophages in the bone sense it that there is abnormal formation of the RBC inside the bone marrow. So they will start to destroy that. So even the erythropoiesis taking place, but the RBC is not manufactured properly. Because of that, the erythropoiesis process will be destroyed inside the bone marrow. So the RBC will not come into the circulation. So this is called ineffective erythropoiesis. In spite of ineffective erythropoiesis, there will be some RBC which will come to the circulation, but that RBC will be destroyed inside the spleen. Now let's go into the clinical feature of the beta thalassemia. Like other anemias, there will be pallor of skin in the conjunctiva, and because of the hemolysis, there will be jaundice. This is another very important feature, the thalassemic phases. Because of the increased erythropoiesis, the facial bone become hypertrophied, and they give a specific look to that face, which is called thalassemic phase, or they are also called chipmunk phase. Because of the same reason, excessive erythropoiesis, the bone become weakened. The medullary, because of the increased erythropoiesis in the medulla, there will be thinning of the cortex, will lead to weakening of the bone, which will lead to pathological fracture. Another very important clinical feature is splenomegaly. There will be massive splenomegaly in the beta thalassemia major patient because of the severe hemolysis. Another one specific reason is this: because of the severe hemolysis, there will be splenomegaly. Another reason you can give is because of the extramedullary erythropoiesis, the spleen become large. And massive splenomegaly is defined as when the spleen crosses the umbilicus. It is called massive splenomegaly. Another, there will be poor appetite in their babies and severe lethargy. Diagnosis. Even the clinical symptoms and the clinical picture is important for the diagnosis. Like whenever a baby is born, before 2 months, the baby will be normal. But in some babies, from 2 months, and some babies up to 6 months, the clinical symptoms starts to appear. So it is because after 6 months, the fetal hemoglobin is replaced by adult hemoglobin. But the fetal hemoglobin is not good. It is not competitive for the survival, because in fetal hemoglobin, the affinity of fetal hemoglobin is very much for the oxygen, but very low affinity when the hemoglobin unloading the oxygen into the tissue level. So in CBC, there will be decreased hemoglobin because it is a type of anemia. It is simple. In the peripheral smear, there will be inocytosis and decrease MCV. So another, we can say the thalassemia is a microcytic hypochromic anemia. This is the investigation of choice. The hemoglobin electrophoresis. Whenever the electrophoresis we do, there will be fetal hemoglobin 98% and adult hemoglobin will be only 2%. And this fetal hemoglobin is not good for the survival. If we look at the bone marrow studies, there will be erythroid hyperplasia because it is a kind of it is in this condition there will be a type of hypoxia to the renal. So in response there will be increased erythropoietin. So increased erythropoietin will lead to stimulation of the increased erythropoiesis, and because of the ineffective erythropoiesis there will be erythroid hyperplasia. Look at the treatment. Monthly blood or every 15 days the blood transfusion is must. Because of the blood transfusion, there will be secondary iron overload condition, secondary hemochromatosis. For that, we will give chelating agent such as deferoxamine or deferriprone, but this is treatment of choice. The bone marrow transplantation. This is treatment of choice. In some patient, if there is severe hemolysis, then we will do splenectomy in that patient. Thank you so much.